joint just posterior to the posterior facet, that is the joint depression, and the number of the fracture line which divides the posterior facet, that is the basis of the Saunders classification. I will show you. So see, so this is the fragment. You can see here. So this is the fragment. This is the primary fracture line. And see, this is the fragment that extends up to the posterior facet. This is the tongue type. Basically, it's a pure tongue type fracture. Whereas this is the, see, this is the partial tongue type fracture. See, it is just it reaches up to the superior edge of the posterior tuberosity. So this is basically the partial tongue type fracture. Whereas these are the fracture. These are basically this component. The whole the posterior tuberosity remains intact. This is basically joint depression fracture. Whereas the double density, see the double density, this is going inside the articular surface. Almost it is so some part you have to see the CT scan for exact location of this component. So basically, it is a joint depression fracture. See this same type of this is the both the double cortical contour. You can see here double cortical contour. If it's a double cortical contour, still this is a tongue type fracture. We have to take the help of the CT. You can see here this is one component, and this component is driven inside that fracture, and that indicates that is a this is a large component. This is a large component which can be easily delivered by the minimal invasive technique if it is preferred.
Yeah, good evening, sir. Sir Siddharth, yes, sir. We are actually running short of time, sir. If you can.
This is the last slide.
Yeah, please, sir.
So this is the Saunders classification. You can see here, basically the posterior facet. I've already told the number of that depends on the number of fracture line. There is on the lateral side is A, the central part is B, and it is in the middle side is a C. So it is a one fracture line, two fragments, the two-part fracture. It is a two fracture line, three fragments, the three-part fracture. It is a three fracture line, four fragment. It is a four-part fracture. But if it is a depression, should be less than 2 millimeter for the four-part fracture. But whatever the fracture line, if the depression is less than 2 millimeter, it is a type 1 fracture. So this is the classification. Thank you.
Yeah, I'd like to.
Sir,
please unshare your screen. Siddharth, are you there?
Yes, I can hear you.
Okay. Do we take questions now or do we go on?
We can go on, sir. I don't see any much questions now. Okay. People are just watching and learning more.
Okay. Then should I share my screen for
Yes, sir, you can.
Thank you very much. Good evening and thank you to the West Bengal Orthopedic Association allowing me to give this talk along with the other people who are joining and giving me their comments. This, I'm going to continue, Siddharth, if you don't mind, despite the people joining. Is that okay?
I will ask everyone to please, Ashok sir, you have become the host. Please, if you can mute everyone.
You are the host, Siddharth.
Okay.
Yes, anyway, I'm still the host.
If you can hear me, can you hear me, guys?
Yes, sir.
I'm putting out a request to anybody who's joined. Please mute yourself, otherwise you're disturbing the flow of the webinar. And the webinar today is on minimally invasive surgery for calcaneus fractures. And I want to start by describing what are the advantages, disadvantages, etc. of MIS versus ORIF, which is the extensile approach for calcaneus fractures. Usually the problem with the calcaneus, as has been discussed, is it breaks badly, the fracture is complex, and the distortion is three-dimensional. So your reduction involves multiple maneuvers, which will have to get the tuberosity in one place and the facet in another. So all that needs to be done in a specific way. And therefore the solution is not so simple. Our aims is the accuracy of joint reduction, which is better with open reduction, remember, but still can never be guaranteed. Second aim is the recreation of hindfoot mechanics, which can be achieved by both MIS and open reduction. And the third aim is managing the soft tissue component, which is definitely better with MIS. And the most important is getting a reasonable outcome. And even today, from the literature, we are not sure which method, the MIS or the open reduction, gives a better long-term outcome. You know, a lot has been written up about MIS for calcaneus fractures. There are so many books. In my book also, there's a chapter. But the issue is often that we forget that all calcaneus fractures are not the same. Dr. Pal described the anterior to posterior line, which is the common one. But there are so many varieties of calcaneus fractures, the tuberosities, the periphery, the anterior process, the sustentaculum, that we cannot give MIS or ORF as one solution to a fracture. So what I want to focus mostly is on DISF, that is the displaced intra-articular calcaneus fractures with a bit of depression. This is what I mean. If you look at the CT-based classification with the cuts taken at the widest part of the talus, Sanders has classified this into 4 types. The type 1 undisplaced and the type 4 comminuted fractures, I'm not going to be speaking about because they are treated differently. The debate is about the type 2 and the type 3, where you can achieve reduction and you get the biomechanics back. And these are the fractures which actually need us to be sure about what type of treatment we want to do for them. Now, the problem with the extensile approach is wound healing. And that is the one big problem. And this is also related to the experience of the surgeon. So this is the reason why MIS started coming into vogue. And today we know that MIS has some proven advantages. And let's see one by one. The first advantage, it's a no-brainer. There is a less incidence of skin necrosis and wound complication. Everybody knows this. The second advantage, it is the procedure of choice when there is a problem in the foot, like poor vascularity, diabetics, smokers, where you know that for sure the wound of the extensile approach is going to break down. The third advantage is small skin incisions. You can have even more than one. You can have a percutaneous method fixed with along with a small incision. And today, Dr. Sharad, Prabhakar and Dr. Smapat are going to show you the sinus tarsi with variations and the longitudinal incision. So you can do anything with the small stabs here and there, even put in a plate. The fourth advantage is you don't have to wait for the swelling to subside. If you're wanting to do an MIS, you can do it early. And if you're doing it with association with a spinal fracture, for example, in bilateral cases, you can do an MIS even in the prone position. So this is a significant advantage for these scenarios. The fifth advantage, in polytrauma patients, it allows early fixation. So you don't have to wait for the skin wrinkling. So it's a continuation of the fourth advantage. But the key point often is the sixth advantage. When you have an open calcaneus fracture, it is the treatment of choice. And this we published also because we saw that in a prospective study done over about 3 years, MIS is undoubtedly the best option for open fractures. Seventh advantage, if you know foot and ankle arthroscopy, you can improve the accuracy of the joint during MIS by adding arthroscopy and then getting very little skin, vascular, neural complications. So remember, MIS for calcaneus fractures is not one treatment. It is a group of methods where you reduce the fracture, hold it till it unites without damaging the soft tissue. That is what MIS is all about. And then if there are many methods for different scenarios, we should know what to use, where, and why. So let's take this up individually, and I'll talk about only 4 methods. The first method is closed reduction and K-wire fixation. And here we use multiple K-wires frequently. And I'll give you an example. Let's take this scenario. Closed fracture, young adult, tongue-type fracture, lots of swelling, polytrauma, smoker. So this is an ideal case for MIS and percutaneous fixation. And that is exactly what was done for this. And initially when we started doing it, when I was younger, when Sharad was younger, we used to transfix the joints for stability because we thought that gives much more stability. But now, as we become more clear about this, when there is minimal comminution and a big tuberosity fragment, you can fix these by indirect methods and percutaneous fixation. Then you often do not need to transfix the joints also. You'll get a good reduction and you'll get a good outcome. Second one, in many scenarios, maybe Smapat is going to be talking about that again, the percutaneous method has been sort of replaced by small incisions and cannulated screws. They can act like the raft screw. All those details will come to you. But by a minimally invasive surgery, you could put in multiple screws into the calcaneus by small stab incisions. And this is actually what has replaced K-wires to a large extent in the modern treatment scenario for us. MIS method third, which is perhaps the most common and most popular method today, and many experienced surgeons are changing to this totally, is the sinus tarsi approach. The approach is at the level of the joint. It avoids the sural nerve. And when you are doing it, you can manipulate the fracture reduction directly by elevating the fragment. Like you see here, we are elevating it, and you manipulate the tuberosity with a Steinman pin at the back. So you can do so many things with a small sinus tarsi approach. And then you can fix it with a screw into the sustentaculum and longitudinal wires which go along it and whatever way. But I'm not going to go into details, but this is perhaps the commonest method being used today. Method 4, you can use arthroscopy, which can be used alone or as an aid to MIS. And lots of studies are coming in, because when you use an arthroscopy, a scope into the subtalar joint allows an accurate reduction of the joint, and then you can do any kind of fixation once that joint is reduced. But hold it. I've told you lots and lots of things which are in favor of MIS. But is MIS really that much better? And if you want to do it, we look at the literature wherever there is. There is no doubt that the soft tissue complications after MIS are much, much less. But there is also data which shows that if you follow up the cases with a lateral approach, the extensile approach, in the long term, these complications really don't influence the outcome. So this is something which we must consider. And let's see what the evidence says. This is the chapter from my book on the calcaneus fracture, written by Mohit Bhandari. There are very few studies which are directly comparing extensile versus MIS approach. So this study by Klein et al. About in 2013 did some direct comparisons, but didn't really come to a conclusion. On the other hand, there are the studies by Weber who compared the sinus tarsi with the extensile approach and said that MIS is better because there are less complications, shorter operating time, but it needs more secondary procedures. But the reduction accuracy and maintenance of the reduction and ultimate function are equivalent in both these operators. So where do we go with this? There's a study from AIMS, New Delhi, which was published in 2014. And this was a prospective trial, but they did not give too much detail about how accurate was their fracture reduction, which is a key point to avoid late subtalar arthritis. So they said that MIS is better, but because it's got fewer wound healing problems and earlier return to work. But I'm not so sure about the long-term outcome because they never commented about the accuracy of their reduction. There's this study from 2016 which talks about better results with OIRF despite complications. But this was not prospective, nor was it randomized. Our study from PGI, which was one of the biggest ones, was an RCT of 21 cases. And we found that despite better soft tissue with MIS, poorer clinical outcomes were seen. And the current trend pointing that MIS is better than ORIF may be misleading. Now, this was work done in 2015. In 2020, we may be changing again. But remember, both ORIF and MIS should be done by experienced surgeons. And even in our experience, if you do an ORIF, the long-term complications are negligible. So remember, MIS does not necessarily mean microscopic incisions. It means soft tissue protection. And if you want to do a good MIS, you have to have good surgical experience. So gentlemen and ladies, what's the take-home message? If you have an open fracture, bad skin, smoker, severe combination, plus you have the surgical experience and arthroscopic training, MIS is definitely better. The more experience you have, the better outcomes you will get with MIS. And MIS, remember, is a variety of fixation methods. Some of them are better than others, but you have to pick the fracture for one particular MIS method. If you have a Sanders 2 or 3 with a young adult with not too much complication, and you have the experience, then maybe ORF will give you better radiology, better subtalar joint reduction, and better clinical outcomes in hands of experienced surgeons. But right now, I will leave it that the balance is perhaps in both sides, and it becomes a personal preference. If you haven't done ORF with an extensile approach, do not attempt MIS. If you've done 50 ORFs, yes, you are the guy who will do an MIRF bet, because the reduction of the fracture in both the techniques is done in the same way. Thank you for your time, and I will now see if there are any questions. I will stop sharing.
Yeah. Good evening, sir. Thank you for enlightening us so much. We were very much got information about it. I don't think so there are much of a queries just now.
Okay, we'll do it at the end.
Yeah. So we'll do it at the end. I'd like to invite Dr.
I think Anjan Pan has a question.
Yeah. Yes.
Not
yes,
the question. I just put on additional thing to Dr. Dhillion that
Yes.
even after these anatomical good reduction and other things, always there will be a subtalar arthritis later on. So whether you go for MIS or go for extensile approach, the problem is that the cartilage damage due to this initial injury, that is the main factor.
Yeah, that's true, sir. There is no doubt about it. It's for any intra-articular injury. But as along with that, it also says that all intra-articular injuries should be reduced accurately. Then there is a chance of you not getting a subtalar arthritis. And many of these who you reduce accurately, the defects left are very little. And the subtalar joint actually sometimes doesn't get arthritic. It becomes fibrosed. You will always lose motion, but they don't necessarily become painful. And it's not only the subtalar joint, you also have to make sure that you get the 3D biomechanics of the hindfoot right, which is always better done with extensile approach. But if you've done a few extensile approach, as Smapat will show you with the sinus tarsi, you can get the same reduction with MIS also. Sinus tarsi is not the, subtalar joint is not the only problem. I agree with you on that.
Can I ask you a question, sir?
Yes, Smapat, please.
Very interesting fact you have enlightened that MIS and open method had equally good results. So what do you think? I mean, is those studies they have compared same fracture patterns? What must be the cause? Because it is really interesting to see that result.
You see, these were studies done from 2005 to 2016. When the understanding of fracture patterns and reductions was being, because this was the same time when people were not very comfortable in fixing fractures of the calcaneus. Then they started fixing fractures of the calcaneus. And most of the guys who did not have experience always had a skin problem with an extensile approach. Now, as people became experienced, their problems with skin incisions became lesser. But also, they were able to sort of reduce them by indirect methods. So their options of doing MIS became much more. That's why I'm saying, if you've got the experience, your outcomes are going to be probably the same, but you will be more comfortable. It's like open surgery for the knee and arthroscopy. People, once you know what is the anatomy and you know what is arthroscopy is definitely 100 times better. So if you can reduce the fracture by an MIS, my personal feeling is you reduce the hindfoot biomechanics, heel height, get it out of varus, lateral wall, and you stabilize it till union. Definitely it's a no-brainer that MIS would be better.
Absolutely, sir. Thank you.
Thank you.
Thank you, sir. Smapat sir, can you share your slides? And
yeah, are you able to see my slides?
yes, sir. Please, you can share
Yeah.
your slide.
Are you able to see my screen?
Yes, sir, we can see your screen.
Okay, so I'm going to talk about the sinus tarsi approach as a minimally invasive approach. Now, as Sir has mentioned very nicely, this is a soft tissue respecting approach. Yet you have to reduce joint and other biomechanics as well. So what do I mean by other biomechanics? It is not only the articular alignment. Look at the height. We have lost height here. Look at the axial alignment. Here there is a varus alignment, and this varus alignment is absolutely painful. Look at this. This is again broadening of heel as compared to opposite side. This is a broadening of heel. Now this broadening of heel is also equally painful, and along with the joint alignment, this particular bump exostosis is going to be painful. So Dhillion sir said other biomechanics. It's true. So many other biomechanics. Look at the lateral bump here. It is going to definitely irritate the peroneal tendons. And of course, the joint arthritis. So we have got all the responsibility apart from reconstructing joint. So much of biomechanics like axial alignment, height, width, length of calcaneum has to be maintained. So you take approach which is soft tissue respecting, but it should reconstruct the biomechanics. Like in this case, it is dorsiflexed talus, which is not good for ankle movements. And this malunited is causing some tarsal tunnel syndrome. So whenever we are choosing the approach, we should choose, of course, sir has mentioned, open approach is not good in these conditions. So I will present what you can do through sinus tarsi approach. Now look at this case. It's a 65-year male, so elderly male. And this is the fracture. Look at this now. Talus has absolutely protruded between the fracture calcaneum. Are you able to see this? This is absolutely going between the calcaneal fracture. Even ankle is subluxated. The displacement of talus through calcaneum was so much that it has subluxated through ankle. 65-year male, I was apprehensive for open reduction. What we did, of course, CT scan for evaluation. And look at this CT scan. The primary fracture line, as Dr. Pal has showed, the fracture is totally displaced. Talus has gone between it. Calcaneum is displaced and talus is absolutely sandwiched between the fractured calcaneum. Now it looks difficult, but if you follow the correct sequence, you will do well with a soft tissue preserving approach like sinus tarsi approach. We took sinus tarsi approach, but you should know what are the things to be done. Approach is one thing, but you should reduce everything. So we pass one K-wire or Steinmann pin from medial to lateral in the calcaneum, give traction, reduce it, assess the reduction through this sinus tarsi approach. Look at this. So I have passed this medial to lateral pin. Axial alignment is maintained. We got the reduction of talus because axial alignment is maintained, length is maintained. That talus which was sandwiched between the calcaneum, which has gone out now. And then I have put one transfixing K-wire. Then this sustentacular screw from lateral to medial into the sustentaculum. And look at the alignment. Very good alignment in axial. This is broadens, very good. And this is how we fix it. We fix it like this through sinus tarsi. This is a follow-up X-ray. This is how the follow-up X-ray. And look at the final healing. We withdraw that K-wire after 6 weeks, and this one is the final healing. Now, 65-year gentleman, if we go for lateral extension approach, I am worried about the healing. No doubt you can do a good job anatomically, but equally good job can be done through sinus tarsi approach, and then these results can be comparable because see this axial alignment, see the length, see this intra-articular step, everything is good. Another case, 25-year female, look at the posterior facet. It's absolutely 90 degree down, vertical. It's absolutely down. Again, Same thing we have done. We did sinus tarsi approach and one sustentacular screw and K-wire. And look at the way it has healed. Axial alignment, length, and the interarticular state. Everything is good. Another case, as Dhillion sir has mentioned, when there are compromised soft tissues like a open fracture, usually wound is on medial side. Now this is a wound here. He is a young male, and this is a fracture. Again, same thing. Soft tissue respecting approach. We took sinus tarsi approach, transarticular K wires, which usually we remove after 6 weeks, and a sustentacular screw. You may vary with the implants. Here we have used 2 wires and 1 screw, and this is how he went on to heal. So it is perfect in articular as well as other biomechanics. Another case, now this is a difficult scenario. He came to us 6 weeks later. Now this is almost maluniting. If you take a lateral extensile approach and gain the length, then lateral extensile approach will not allow a good soft tissue healing. So even this we treated with a sinus tarsi approach, osteoclysis, good axial alignment, good fixation, and we withdraw these wires after 6 weeks. This is the final healing, and I have a video also which I'm not going to run here. We can even put on in the other cases screws. I will just show you other case where we are using along with these screws some other parallel screws. So here is a 60-year lady, and look at this facet, again vertical. So in this case, here this vertical facet was elevated by sinus tarsi approach. I'm going to show you video. See this, now I have passed on the sustentacular screw, and as Dhillion sir was showing, I'm passing 2 screws here. So choice is yours. It depends on what injury needs. Here it needed some support, subarticular support like this, which is given by these cannulated screws and a sustentacular screw. This is how it healed. Even you can insert a plate if it is needed. Now this is a distal radius plate, dorsal plate. You can even use that plate through sinus tarsi. Look at this, and I will show you video. So you can put various implants, but as Dhillion sir has mentioned, you have to restore the anatomy, biomechanics correctly. Look at this. This plate we have inserted, and this is how he was a pilot, and he went on to heal and again joined the forces again. Here, very bad comminuted calcaneal fracture plate, which is anatomically designed plate, a costly plate, but even you can insert it like this. So beautiful reduction through sinus tarsi. You can even insert this. I'm running a short video, few minutes. I'm just going to show you. This is axial view. At the end of video, I'm going to show you how to see this axial and Broaden's view. I tell you one thing. I tell my all junior surgeons, don't start the case unless you see a good axial view, and don't leave the OT unless you see good Broaden's view. So this summarizes all. You will see the joint. See this. Patient is in lateral position. I am standing behind. See him from front. I am externally rotating to see the axial view and Broaden's view. See, 30-degree angulation, 40-degree angulation, you see a good Broaden's view. This is the sinus tarsi approach, tip of fibula and 4th metatarsal base. I am going to draw a line from tip of fibula to the 4th metatarsal base. And as Dhillion sir said, you can go little bit early when the soft tissues they resolve, little bit early. Like lateral extensile approach, you have to wait, but for almost 10 to 12 days. But in sinus tarsi approach or minimally invasive approaches, you may go in little bit early, but of course, you have to respect the soft tissues as much as possible. So we are going to start this incision at the tip of lateral malleolus, and I'm just going to run it for 2 minutes more. This incision is going to go in sharp, but in layers. So yeah, This is the incision, and you will not be able to see. Yeah, you will not be able to see unless you cut the calcaneofibular ligament. Now, when you want to cut calcaneofibular ligament, I will advocate such bump under the middle malleolus so that you can invert, give stress to that calcaneofibular ligament, protect peroneal tendons behind, and I will show you how to cut that calcaneofibular. See this, it's a big ligament. It's a big ligament, okay? Calcaneofibular. When you cut this calcaneofibular ligament, then only you will be able to visualize the subtalar joint and the depressed facet. Here in this case, that facet was depressed almost vertical, and I will show you how to reduce that joint. So this is the calcaneofibular ligament, and this is what we are cutting. Once you cut this, you will immediately see the part which is displaced down. Sorry, it has become slow, but I'm just going to finish in 1 minute. See this, I'm going to cut that calcaneofibular ligament. My one retractor is protecting the peroneum, and other retractor is on the superior side. And I'm just going to, I have just cut it, the calcaneofibular ligament. Now look at this. Once you cut it and invert it, see this, you are able to see the talus posterior facet. And now here you have to visualize the posterior facet of calcaneum, but you cannot because it has gone down. So what, see this is a posterior facet of talus. So what I'm going to do, I'm going to insert something like homons or an osteotome, and I'm going to elevate it, the posterior facet, between the lateral wall of the calcaneum and little behind. So this is it. I'm going down, and I'm going to go below the posterior facet. I'm going to give little extra bone to the posterior facet, and then I'm just going to elevate it. And you will see even in this video, which is actually not well shot, but see this now. I will show you how it is going to come up. And take talus as a template. Now see this, this is a talus, and I'm going to elevate it. And once it is elevated, you will see that it very well matches. Yeah, and just give me 1 minute. It is going to, yeah. I'm going to give you a good view of it. Just a minute. Sorry. So because of, once you elevate it, you can even pass a screw or plate on the lateral wall. If it is needed, you can pass K-wire or small plate. And but this is one part of biomechanics. As Sharad said, this wire which act as joystick will correct first length, axial alignment, length, width. Particularly the axial alignment is very essential. So everything can be done through the approach, but provided you know what is to be achieved, and it has to be soft tissue respecting approach. And I will show you the last thing, how to see the Broaden's view. See, this is how we see a Broaden's view. Don't expose your hands. You can just put on this sterile bandage. This is oblique Siam, and it will show you the Broaden's view. So friends, it is a soft tissue conservative approach, but you should know all the biomechanics, how to achieve it. Thank you so much. Over to you.
Yeah, sir, there's a question from Dr. Debasis Mukherjee. Sir, if you can please tell us in few steps in your pictures how to approach in a comminuted fracture in a sinus tarsi approach.
Okay, so basically you should read the fracture properly. So it is not one method for each and every fracture. Read the fracture properly. If you think that I can address this through sinus tarsi, what you should do is make a plan. First thing is to get the calcaneum out of varus, because unless you get the calcaneum out of varus, you are not going to reposition the facet back. So first you should get the length, get the good axial alignment by putting one Steinmann pin, either mediolateral or axially, whatever way you want. Take sinus tarsi approach, reduce the facet, confirm with axial and broadens view, that is most important, and then you choose what you want to put as implant, either screw alone or with small plate or transarticular K-wires. Choice is yours, but read each and every case properly. Sometimes you may have to just treat it as a bag of bones through K-wires which are transarticular, but as we have repeatedly telling you that all biomechanics has to be given consideration.
Small comment about excessive comminution. If you've got very, very severe comminution, that's when you're worried about. Then you really want, even with the MIS or even with the extensile approach, you want the hind foot heel height, getting it out of varus. You may not get 100% accuracy of the subtalar joint. But and even Dr. Anjan spoke about it, as accurate as possible as you can, because the intra-articular arthritis or cartilage damage sometimes is not in our control. Yeah. Get the hind foot mechanics back, get the lateral wall depressed back, as much of elevation of the depressed facet as possible, heel not to come out of varus, volar angle to be reconstituted. I think that's the best you can do if there is too much combination. It's the same as any articular fracture.
I agree, sir, because even if later he lands up in subtalar fusion, still you want good axial alignment, good height, good width. So absolutely agree with you.
Smapat sir, there's a question. I was actually inquisitive, sir. The reduction technique, either in open or a sinus tarsi or a minimum invasive approach, is the same.
Yeah.
Isn't it?
Yes.
Can you enlighten us more?
So,
because you're doing it with a K-wire, putting a traction is the same way you're doing an extensile approach also, right?
Yes, because you cannot handle those fragments the way you want. Still, it has to be soft tissue respecting. So try to use K-wires as a joystick. That's why I said, Dhillion sir showed you one joint depression. Joint depression type, you can just maneuver with the posterior tuberosity K-wire as a joystick. But then you have to see fracture geometry and try to be soft tissue preserving and try to use K-wires as a joystick. But it will be allowed only when you first take the calcaneum out of varus or valgus. So first achieve length and then you try to put the facet back.
That's exactly what I meant when I said that you have to have the experience of reducing the calcaneus first before you want to do an MIS. If you need to learn by doing an extensile approach, because then you can actually see the fragments you are manipulating. Once you're comfortable of the 3D anatomy, then leave the soft tissue envelope closed and do the exact same manipulation with a minimally invasive procedure. So the method of reduction, the aim of reduction, and the aim of fixation in both of them is the same.
Thank you so much, sir. I hope we have enlightened everyone with the questions. We'll like to move ahead. I'd like to invite Dr. Sharad. Yeah. If you can please share the screen on and say something on MIS by open envelope approach.
Yeah, doing that right now.
Thank you so much, sir.
I'm grateful to the organizers and Professor Mandeep for giving me an opportunity to speak. And we did this with Ankit, who was our junior resident, and I'm thankful to my junior and senior residents. So Sir has talked in detail about the advantages of extensile versus MIS approach. There was one question that if you've started doing an MIS approach, can you convert it to an extensile approach? So it depends on what exactly you are trying to do. If you're doing something percutaneous, for sure, you could make it an open incision. If you started doing something like a sinus tarsi, you would not really be able to convert it to an L-shaped flap later. So if you have to take a call before you start, what is it that you want to do, and whether you can manage this fracture in a minimally invasive way in which your visibility may not be that much. So that call has to be taken previously. The question regarding whether you can use regular plates or do you need to use screws or wires, it's entirely up to you and also dictated by the approach. So in a sinus tarsi approach, like Dr. Smapat showed an excellent presentation, that you could use a radius plate, you could use a plate that's angled to the back. The approach that we have sort of evolved, you could use a conventional plate as well. So again, it is approach dependent as to what implant you can use. K-wires and screws for sure, you can use it with any approach, I guess. So like for any minimally invasive approach, we don't wait. We do surgery as early as possible. The longer you delay, the more difficult it is. The position we do use a tourniquet. You position the patient in a floppy lateral position and a large radiolucent sheet roll under the foot. If you've got concomitant spine surgery, you can position the patient prone. This can also help you with bilateral fractures. And then you can position a C-arm and do the same. So just starting with a few examples. So we show that you've done your radiology, you've done your lateral views, axial views, you see a tongue-type fragment here, and the articular surface has become almost vertical. Get your CTs done to see your fragments, and then classify according to your Sanders classification. So the open envelope approach essentially combines the posterolateral approach to the ankle with the longitudinal limb of the extensile calcaneus approach. And you go down the skin, elevate the soft tissues, you remove the retrocalcaneal bursa, and it exposes your subtalar joint. Basically, a periosteum elevator is used to lift the soft tissue envelope off the lateral wall of the calcaneus. So a small video clip here demonstrating the use of an elevator to lift that envelope off. So this started out as a single incision approach and evolved to a dual incision approach. So when we were starting out initially, we would give only the longitudinal limb, and you are essentially lifting a flap without having any angles to that flap. The rest of the reduction usually proceeds in the same way. You have direct visualization. You can manipulate your tuberosity fragment, get a bone hook in there. You can see the talar articular surface. You can usually see the articular surface as well of the calcaneus. You can manipulate the fragment as you want. So this is what we show here as a periosteum elevator. We're lifting the depressed fragment. You get a void that on your C-arm, there's your bone hook over there, and you temporarily fix it with the K-wire. And these are one of the earlier cases we fixed with wires, and with a single incision, we fixed it with wires. We do put a drain later, and that's the post-op X-ray. Another patient, 26-year-old male who had a motorcycle accident. This was a bilateral calcaneus fracture with lumbar spine fractures and poor skin conditions. And so that you can see the skin over there, and then you have X-ray and CT, and you have a intra-articular fragment that's almost vertical and split. So we position the patient prone, and that was how we positioned our C-arm. And so one of the things this approach lets you do is actually manipulate that depressed fragment directly. So you can access that fragment, you can take it out, clean it, position it the correct way. You can see the articular surface of the talus right there. And you can proceed as if as you would do for any other fracture. Like previously discussed, the steps for reduction remain the same. So you can take the fragment out, you can clean the articular surfaces, you can reposition that fragment. So you can see the subtalar surface very clearly here, and that's your hook that's coming out to the back there. So again, these are initial cases. We have used only K-wires here. You can very well put screws, or you can even slide a plate, which will come in a subsequent case. So we do call it the $1 surgery, about 10, 20 rupees a K-wire. And for poor-free patients, it's about like 60 rupees a foot. 4 months, and that's the guy walking there. So another case, a 22-year-old male. This was a roadside accident, left-sided calcaneus fracture. And again, a joint depression type of fracture pattern, and you can see on the CT, the split over there. So again, it's emphasizing the skin incision, the longitudinal limb. You dissect the proximal incision with scissors, and you go right down to the bone as you would do for a conventional flap, except that you're not making any angles to it, and you lift it off with your periosteum elevator. So use an osteotome or a periosteum elevator, lift the soft tissue envelope till the calcaneocuboid joint, because you want to expose it completely. And then you can use a bone hook, your articular surface is visible, you do the reductions that you want, hold them with K-wires. So fragment manipulation. And this is just to show that the wire is being put while you're holding the reduction. And this you can do directly. We gradually evolved a second incision from where to do it, which is right there. So this is that we are sliding a plate. And this is one of the regular calcaneal plates that you can get. You can use any plate that you want. And once you've held your reduction temporarily, you check under your C-arm. The second incision here lets you manipulate a small vertical incision, make it under a C-arm and use an artery forceps to go down to the bone, making sure that you have retracted your tendons away. And those are the x-rays. So emphasizing here the second incision, just make a small nick, use your artery forceps to dissect and make sure when you pull the plate in, the tendon doesn't get entrapped. So the artery goes under the tendon and you can pull the plate in. So there is a suturing. You do not need to sequentially suture. Another patient, a 33-year-old male who's a smoker and a large sebaceous cyst here. So again, non-affording patient, we went in, manipulated the fragment, and there's an intra picture that's actually showing the void that you get when you reduce that fragment, and the KVIs are even visible in that void. So visibility is okay, and you find that you have reduced your fracture, make a confirmed reduction at the C-arm, and then you suture it, and again, that's over a drain. So there's your final picture there. Another patient, a 33-year-old male, a road traffic accident, a large tongues. So we essentially involved a second incision, not only to get the plate in, but also to manipulate these large tongue-type fragments. He also had a medial fragment and using a clamp to compress it. And the systemic and the constant fragment is now no longer constant, and putting a screw to that. And there's the wound, that's the healed picture, showing the healing is adequate. So what started out as a single incision, it gradually evolved to a double incision. And this is an iconic picture here showing the arcade and lateral calcaneal arteries in the nerve. So when the longitudinal incision is behind the nerve, you're just adjacent to your tendoachilles. The other small incision is just a nick in the skin, and you're using your artery forceps to go down to the bone, taking care to take care of the tendons. So as already talked about this study. So this was initially a part of a larger study on 70 calcaneus fracture this sir talked about. And so the only thing here that in the subgroup difference, so we had adequate reduction of the bolus angle. The difference between extensile and MIS was not statistically significant, but that's because an MIS is a mixed bag. And when we compared limited open to extensile approach, we were found that they were comparable. We published this in IGO. So this is not a one pill for everything. This is only one of the approaches for the calcaneus fractures. So as we have evolved, it has a learning curve. We now have a shorter surgery time. We preserve vascularity. There is no angled flap. So there's no flap necrosis. You can directly see your fragments. Lateral wall impingement can be addressed. You do not need sequential suturing. You can use a regular plate or a screw or a wire or what have you, depending on the sources you have. So it's just respect the soft tissues. You can lift your envelope up and not tear the envelope. Thank you.
Thank you, Sharad. I think there's Dr. Bakshi who wants to ask a question. He's got his hand up.
Yeah.
Can you?
So you muted, sir, I guess.
Is it okay?
Siddharth?
Is it audible?
Yes, Bakshi, yes, you're audible.
Yeah, in many of the cases, I've seen that there is a void which is still persisting even after the reduction of the KYs you are joysticking. I just want to know to all the expert panelists whether what is the percentage of bone grafting it is essential in your experience.
Dr. Bakshi, you live in Kolkata?
Yes, sir.
What is the chance of the Howrah Bridge collapsing? There's nothing underneath it. Has the bridge ever fallen? There is nothing underneath it. Okay. So if you can reconstruct the anatomy of the calcaneus, there is nothing required in that area of the ward. That is actually equivalent to the Ward's triangle of the proximal femur. You know what the Ward's triangle? Yes, it's an empty space in the neck of the femur. So this is the equivalent area of the Ward's triangle. It becomes more pronounced because the residual bone here becomes compressed. But if you can reconstitute the main calcaneus like a bone and it heals, you don't require anything under this. And the example I give to all my friends in Kolkata is the Howrah Bridge. It doesn't fall. There's nothing underneath it. So there is no, and I repeat, absolutely no need for adding supplemental bone grafts. You may have a 1 in 100 case scenarios when you're not able to get an accurate reduction. And then there are people who put in bone paste and they are put in even some chunk bone grafts also, so that they prevent late compression of the facet. So that sounds reasonable, but in a routine, I don't think it's required, sir.
Okay, thank you, sir.
Any more questions from the audience?
No, sir, I don't think so. Anyone has a question? Sir, we can move ahead and
then
MIS on open fractures.
Open fractures. If you guys don't mind my talking too much. Okay, guys, since you're talking about MIS, you have to understand that you are also talking about open fractures, because this is the best thing you can do for open calcaneus fractures. You know, we all know what an open fracture is. Whenever there is this break in the skin which allows direct communication of the fracture or even the fracture hematoma with the exterior, it's an open fracture. And the incidence of calcaneus open fractures has been documented to be about 10%, which is quite a bit. But unfortunately, in the tertiary care center where I work and Sharad works, we get about 30% of these cases having some degree of wound around the calcaneus. So remember one thing, an open fracture is a totally different injury. The challenges to treatment are unique. And in this kind of scenario, we have to understand that it is the soft tissue injury which will determine the outcome, not the reconstruction of the calcaneus as a bone. That's the key point. So as long as we understand that, we are going to be okay without this. So the first issue in an open fracture is addressing the soft tissues. So the standard classification applies. There are the type 1, there are the type 2, and the type 3 fractures according to Gustillo and Anderson. And you can work easily with this classification. But remember, it's an inside-out injury most of the time. If you have a fall, the compounding is mostly medial, because when the tuberosity shifts laterally, the medial structures tense and they tear. So it's a simple cut like in this side. It is because of a tear of these structures. But you can have another mechanism. But with the fall, most of the time, the compounding or the opening is on the medial side. But you can have other cut injuries, you can have a run over injuries, you can have industrial trauma. You will get various types of presentations of calcaneus fractures. The other issue is you have to think about the wound location, because you have to plan your surgery. And sometimes you may even get penetrating trauma to the heel with even a plantar bone spike. All these things will influence the decisions regarding your treatment. I'm going to show you a case. In Punjab, they have these kirpans, their swords, they go around very commonly. He was involved in a fight and somebody cut his heel with a sword. So if you look at this X-ray, the calcaneus is cut through and through, just below the peroneal tendon. Would you believe his luck? He had an injury to the sural nerve, but it was a purely extra-articular fracture. And what can we do for this? Putting in K-wires or even screws, if I see him today, is the best thing. It is so easy to reduce this fracture that you don't even see the fracture line after the reduction. But the problem is the soft tissue. What do you do about the soft tissues? And at that time when we were treating this patient, we did a primary split skin graft because the issue was covering the back of the heel, and this graft broke down because everybody knows graft over a tendon will break down. This did not take, and he had to have a flap which was done by a plastic surgeon. And today we know that this is something which had been done in the first place only. So a relatively simple bony fracture, calcaneus cut fracture, was made complex because of the soft tissue injury and our poor understanding of how to manage this soft tissue. So it's important for us to understand from day one that we must manage the soft tissues much better than we do in any other treatment. Other issue is the configuration of the fracture. You could have a minimally displaced fracture. You could have a significantly displaced fracture. You could have a fracture with a lot of combination, and all depends upon the mechanism of trauma, and the treatment in these open fractures would also be different. Now, this is a bilateral fracture. In one side, you can see that the combination and the compounding is on the plantar surface. The other side, there was a conventional shattering and there was compounding on the medial side. You can also have associated injuries like ipsilateral calcaneus, talus, midfoot fractures. All of them will influence your treatment. You can have an ankle fracture, a foot fracture with an open fracture, or foot dislocation. All of these will influence how you manage these open calcaneus fractures. Big issue is polytrauma. Whenever you have an open calcaneus fracture, polytrauma issues and comorbidity take a priority, because you know life comes before limb and then you address the fracture. However, even while life-threatening issues are there, you need to wash and splint this calcaneus fracture. And once the patient is stable, then you can focus on the local injury. This is a case who had multiple injuries. And if you can see, there's an ankle fracture, there's a fracture over here, and there is a wound on the medial side. So this guy got all standard medical management, including tetanus, antibiotics, everything. And then he was taken up because the soft tissues take precedence. So first you irrigate, you debride, and if possible, you aim for early closure. It is important that you do this as soon as possible. Once that is done, all the principles of MIS apply, and you can use a transverse shank pin to reduce the tuberosity and multiple K wires, as we did over here, to fix the fracture. And you can add an external fixator to keep the tuberosity down in its place. And this is a simple Indian jet fixator, which we have used in this scenario. And you were able to get a great reduction of both the ankle as well as the calcaneus with an external fixator, which often serves as the definitive fixation of this fracture. So another case, a avulsed tuberosity, comminuted, significant soft tissue damage. You can manage it by X-fix and K-wires like you would do for any other open fracture in the body. But remember, when the fractures are more complex, you need to triangulate this fixation, because not only the heel height, but the foot height has to be done, and the proper alignment of the heel has to be maintained. So here you will have to put a longitudinal fixator in the foot also, and it will look after everything. So here you have to triangulate these fractures and get a good outcome. Anybody who's interested, we've had a international publication on effectiveness of MIS, and I'm willing to send you reprints of this. It's actually free online if anybody goes and looks at it. But remember, in open fractures, you have to be a little more fluid in your thinking. You try to use a combination of techniques, which helps to stabilize the fractures, but minimizes the interventions to hold the calcaneus in its place. That's why, like in this case, this is again compound, the whole heel flap is avulsed and gone downwards. So in this kind of scenario, we were able to fix this with screws, and this K-wire is not for the calcaneus. It will hold the heel flap while the graft takes. Otherwise, if the heel flap is mobile and it necroses, you will have the worst kind of outcome possible. Can we do conventional open reduction in these open fractures? Well, you shouldn't do it primarily, because you will have 100% complications of open reduction and internal fixation. Exceptions to this are when you have an avulsed tuberosity. This is the case of a left foot smoker, and the avulsed tuberosity had caused a grade 1 open fracture at the back. Remember, the skin is threatened, and in a very short time, if you don't look after this simple fracture, you don't even need to waste time getting CT, it will break down. You need to debride it early so that you can make your incision, and you do not want the skin to break down like this, because then it will not heal as well as possible. So these kind of scenarios, you do an immediate reduction and internal fixation, and these are perhaps the only open fractures where you do immediate open reduction and fixation. Most times, if you want to do an open reduction and internal fixation, you need to do a staged open reduction and internal fixation. And what do we mean by that? Staged open reduction is you do a debridement and a temporary fixation. And if you think you want to do a later approach through the lateral side, you can do it. Like this case, which was given to me by Dr. Lawrence from the US. He did an initial external fixator till the tissues healed, and then he went in and did a staged fixation with a plate on the lateral side and got a good outcome. In open fractures, remember, there is only one issue, and that is the reconstruction of the soft tissues. Large wound, minimally displaced fracture. So it's the wound here which is a problem, not the calcaneus fracture. What can we do? The answer is simple. Even in this case, you should use minimally invasive injuries. And this guy had a fracture of the tibia above and a fibular fracture. All of them were addressed by these methods. And the thing is that you have to get your skin grafts, split skin or a flap as soon as possible. And if you do that, good outcomes, even in complex cases, are possible. So remember, it's the skin cover, even in any kind of calcaneus fracture, which is essential. And you should have your plastic surgeon colleagues with you to give you flaps at all times. Some fractures, unfortunately, are open and are non-reconstructible. So don't try and do too much for these. Sometimes you can end up with a calcanectomy. But if you lose the heel fat and there is a problem of viability of the foot, or they come late with bad soft tissue, you should have amputation in the back of your mind. Because complex fractures with contamination and bad wounds, poor vascularity, no heel flap, you need to discuss with the patient that I am trying to try it, but it may end up with an amputation. So the complication rates are very high. Some people say as high as 78%, half of which are soft tissue complications, and the infection rate could be around 25%. And the eventual amputation rate can be high. So this is something which has to stay in the back of your mind when you are treating an open calcaneus fracture. But all is not bad news. With appropriate soft tissue and bony management, you can get good outcomes. And remember, it's either percutaneous, MIS, or a staged management with full importance given to the flap. That is the key. So in a summary, remember that open fractures are serious injuries. The mechanism of trauma could be unconventional. The treatment depends upon the soft tissue damage and associated injuries. So you have to look at everything before you start looking at the X-ray, because here is one condition where MIS is perhaps the best option. And since molds of the wounds are medial, if you want to put in a plate, you could do it in a staged manner over a period of time. All you must think about are the high complication rates. Whatever you do, complication rates are significant. This is the case I'm going to end up. This is not my case. This is from the AO archives. Bad fall from a height. Look at the displacement, the midfoot dislocations, soft tissue damage, primary fixation, debridement, screws, and reducible soft tissues could be sutured. And this leaves both the patient and the surgeon happy. Thank you very much for your time.
Thank you so much, sir. Sir, there is a question from
Please.
Dr. Vimal. He's asking, most of our patients are labor class and cannot afford imported plates. Not all Indian companies are making plates for foot and ankle surgeries.
Okay.
Can panel suggest? It's a very basic question.
That's a very basic question, unfortunately or fortunately, whatever you could say. But the issue is that you have to understand that you have to do what you have available with you. It's not an imported plate which is important. So many of us have shown you just K-wires. And as Dr. Sharad Prabhakar told you, when this surgery was started, he started calling it very innovatively the $1 surgery. The key point is you have to reduce the fracture and you have to hold the fracture and you have to avoid weight bearing till the fracture heals. You can hold it with your hands, I don't care, but K-wires will work, external fixators will work, indigenous combination of screws will work. Smapat has shown you just 1 or 2 screws with a K-wire, 1 or 2 screws with a simple longitudinal plate. Whatever you want to do, understand it is not the implant that is important. It is the accuracy of reduction, saving the soft tissues, maintenance of reduction. That is what is important.
Sir, one more question, please. Sir, one question.
You will have to speak up loudly, Dr. Bakshi.
Yes. Sir, in cases of where it's already 6 weeks old, fracture of the calcaneum, is there any advantage if we put the gest fixator and continue the gest fixator post-op for 3 weeks, whether it will help in the reducing the subtalar arthritis? Because
Sir, you have probably not listened to all the talks today. What we have said is either by open or by MIS or by percutaneous, reduce the fracture and the tuberosity. How you hold it is a secondary thing. With K-wires, JES fixators, definitively, I mean, I've used JES fixators as the definitive treatment in patients who I don't allow to walk. But do not go to fixation. First, reduce it, then hold it. Most of us are talking which plate to use. I don't care. Please learn to reduce the fracture and then hold it with what is possible in your circumstances. Don't start with the plate as the first thing. Just fixator is fine.
no, sir, what I want to say is I'm not telling of the just fixer, whether the distraction of the joint actually helps to reduce the arthritis after accurate
Sir,
reduction.
that is
Does it
during,
help?
that is at the time of reduction. If you distract a joint and leave it badly reduced, it's not going to help the arthritis. Please
No,
understand.
so,
To
my,
reduce the subtalar joint.
now, what I want to say is that in a old case, whether after surgery
No,
and accurate reduction, should,
yeah.
is there any advantage if we continue with the just fixators to distract the joint for
Sir, in
another
an
15?
old case, you are probably looking at a malunion. Okay.
Yes,
And
sir.
remember, all malunions don't necessarily become symptomatic. Please understand this. So if it is very grossly deformed or the patient is very symptomatic, we get patients in our institute, we cannot often see them before 3-4 weeks, or we cannot operate them before 3-4 weeks. So we see what best we can do with the closed method, and then we take them up if they come with a problem related to malunion. That is a different thing, different topic of discussion outside this seminar. We are talking about minimally invasive methods to reduce acute fractures and hold them. That's the thing. That would be probably part of a malunion seminar, which we probably think of doing. The Indian Foot and Ankle Society is doing next.
Thank you so much, sir. Before going to Dr. Ranjan, I'd like to invite Dr. Ujjwal, sir. He will speak on methods of MIS calcaneum fixation. He's a former consultant of Cornell University, London, and currently working in Fortis and AMRI. Ujjwal, sir, if you can start sharing your slide share.
Yeah.
So
Before you start, I just like to say one small point. I have to leave the webinar at this thing, and I'd like to thank everybody who has been part of it. Thank you so much for enlightening me with everything you've said. Have a good night, folks.
Thank you.
Thank you,
thank you, sir. It was our pleasure.
Good evening, folks. Thank you very much, Professor Dhillion. I hope you know everything about a calcaneum. I just want to go back a little bit further. In the prehistoric times, as you have mentioned about Ward's neutral triangle, I must elaborate on that because the presence of this region of a sparse trabecular bone is best explained through close analysis of the evolution process that we humans have gone through. Because certain species that necessitate falls from height to survive a foot anatomy, they have stronger calcaneum. But humans have evolved in such a way that the axial loading mechanisms are like falling from a height or supraphysiologic loading leads to a fracture through the Ward's neutral triangle, which is the commonest site of multiple fragments or the primary fracture line that goes through the Ward's neutral triangle. Probably this helps us to understand more of the ways that we can treat the fractures. Are you all listening?
Sir, please go
Yes.
to the slideshow mode.
Yeah, slideshow I've already shared.
Yeah,
No,
it's
the
slideshow.
Oh, all right. Okay. That's fine. Do that. Is that okay?
Yes.
So there are many ways to build a cat. Yeah. So that's what I'm trying to say here, where we are not allowed to do this as normal humans, and falling from high, because that's not what we are meant to do. But it happens, and the most of the axial loading happens to the calcaneum, and the calcaneum has got some natural weak points through which these fractures can happen. You can see that there are 3 compression trabecules And there are two tension trabeculae, and the compression trabeculae and the tension trabeculae, there is a triangle called the Ward's neutral triangle. And most of the fractures happen through this area. And henceforth, this is important for us to understand the anatomy here, as already mentioned before, that this area will help us to know the methods of fixation on the subchondral bone here, which is the thickest area, and that's where we have to decide on. So as we have already understood about the mechanism of fracture, the joint depression type, the central depression type, the joint depression type or the tongue type fracture, which is important to realize that this type of fracture happens mainly through posterior to anterior direction. The axial loading happens, and the pull of the tendo Achilles helps to get this type of fracture. So what we have to understand, this basic essex-lopresti classification to know what we are treating and what are the things that we are required to do. So the historical treatment of fractures, as you know, started way back in 1908 with ORIP of calcaneal fracture, and they said this is contraindicated. And then somebody said that nailing custard pie to a wall. This is so true, even in comminuted fractures. But in the last 1990, 2005, our thinking has changed, and the thinking was whether to operate or not to operate. But as Dr. Dhillion has already suggested, you got to operate in certain fractures, and we have to think about our expertise on that, and then how we can treat them as you have suggested, that open reduction internal fixation is one of the best methods, but there are complications. So we have to understand the classification method, which is everybody knows, so we can decide on the surgery depending on that. So here is important to realize that the operative treatment in DISAFs is you need to allow reduction of the calcaneal body and restore the height, length, width. Everybody has mentioned that. Lag screw fixation, lag screw technique, lateral neutralization plate of the body, everybody has shown. But the learning curve is very important in MIS. One needs to do at least 50 cases or 2 years of experience in open reduction and internal fixation before we can start thinking about doing MIS surgery in these types of fractures. So here I'm going to show you certain trends which are being done. This is minimal invasive screw fixation, minimal invasive plating fixation, plating, invasive locking plates, and minimal invasive calcaneal nailing system, right? We already have seen about the K-wire, how we use it, and to our best advantages, and an external fixator as well in the Indian aspect. So here we go. The sinus tarsi approach is the current trend, as already mentioned, and you've seen the video. But here is a essex-lopresti technique, one of the most earliest technique described by using a Gisson spike to reduce a calcaneum from the lateral side of the calcaneum and actually to hold the fragment and hold the calcaneum and improve the axial length. So if you can get the axial length correctly, as mentioned, we can do wonders. So this is the first step, as already mentioned. So here you see one of the fractures like the avulsion, but it's not a joint involvement. So you can just use a minimal invasive screw fixation. This is one of the most simple methods of fixation that you can do with cannulated screws, right? Extended indications, Sanders 2, Sanders 3, where you have so much of combination. Here is go another, you can use still screw fixation. Suppose in this fracture, it's got a joint depression type, central depression, and then you can reduce it. And most important thing is the subchondral bone, where you have to maintain the Bowler's angle and the Gisson's angle has to be maintained. So that has to be done on the table by doing the lateral view and the Broaden's view as mentioned, and to see your sustentaculum tali fixation first. And once you have done that, you would be able to then reduce the rest of the fractures together and put them together. This is a 6 months post-op fracture fixation and a good outcome. You have another method of screw fixation, like you can do anterior to posterior fixation. You can do
caudal to cranial fixation, but according to the type of fracture involved, you can use this type of cannulated screw fixation in multiple directions to hold the calcaneum in position, maintain the height, maintain the length, maintain the rotation. So this is very important. The rotation is so important for the subtalar joint because the most important issue here is this subtalar joint. And when you do a sinus tarsi approach, this type of method, you can see the articular surface and maintain that. So these are the methods. You can have a longitudinal incision or you can have a sinus tarsi approach. You can use a normal calcaneal plate. You just have to use this kind of approach to put the plate in after. But there's important thing. If you have a comminuted fracture like a Sanders 2 or Sanders 3, then you can have a special calcaneal reduction clamp. Very important because the articular, the calcaneal surface, you can hold from outside and compress them together. And with the pull on the axial side, you can reduce that subchondral angle. The Bowler's angle can be appropriately reduced. Here you can see another X-ray where you have reduced this, and this angle, Bowler's angle, is this is the Gissan's angle. So this is maintained, right? So this is very important. Even you can accept 2 millimeter of articular defect, so that doesn't harm. But if it is more than 2 millimeter, your sinus tarsi approach will get you the guide. What I do is put in a K-wire from the back of this to subchondral bone to hold the two fragments together. So this is one. This is another fracture here. You can see this is a Sanders 3, and we have put the angle together, and this is the final outcome. So this way you can use a small plate. I am very much worried about the bigger plates in a minimally invasive fixation. I use the smaller version of the plates, which is usually are used Biomet, and they have got a specific and also Arthrex. They have got a specific jig along the axis of this plate. So this is a Biomet fixation device, which has got a similar kind of a jig, and through which you can use different guide wires into the holes, and you can use your method of fixation by putting some locking screws through them. So here is a locking plate, very cumbersome. This seat to the right side, this is a Dupuy cumbersome, I call it cumbersome plate. It's very difficult. I know I haven't had the experience of doing this, but a small plate like that will give you a good idea that this is very important. I can fix with some screws and a plate. So this is important that you can have two methods of fixation. It is important to know there's a calcaneal nail by another company called Medina or Lavender Medics from United States. They are using this kind of nail, which is a short nail, and you can use through the nail different screws to fix the fracture. So here is an example of a nail, which is like this. You have to identify, the most important is the identification of the type of fracture, that you have the pattern of fracture, on the basis of which you should have an armamentarium of instruments and implants with you, which will give you a proper guidance for the surgery. Yes, articular surface is the most important aspect, but then you have to maintain that reduction and hold them together. So this is very important. So here is a comminuted fracture. You can see a talus fracture along with that. So what do? You can use like this, an external fixator to maintain the length of the calcaneocuboid length, which is very important for your foot to function. And you can use some K-wires to hold them together. And at the end, the picture would be like this. And you can use K-wire cannulated screw fixation for your talar fracture. So this kind of fracture fixation is very much well accepted. Only thing is that you don't want to put the patient through weight bearing, which is around 6 to 8 weeks, which is also for your other fixation methods. So this is another way of treating X-fix, which already Dr. Mandeep Dhillion has suggested. And so at conclusion, percutaneous treatment minimizes the soft tissue complications and postoperative scar formation, and it leads to a less incidence of subtalar stiffness and peroneal tendon dysfunction. Thank you very much.
Thank you so much, Nitin, sir, for enlightening us. I'd like to invite Anjan, sir, if he can start his presentation, start his slide share. Before going to Anjan sir, if you can just start, I'll ask Ujjwal sir, there was one case of yours where the testiculum part was not holding with a screw. It was lying independent. So do you think putting a screw through this and holding the testiculum part would have given you better fixation?
It would have been better, but I was holding that with a K-wire. When I missed that, I didn't want to do any more damage because it's a one-go affair. You cannot do it 2-3 times trying to put the pins in, and it becomes a mess in a calcaneal fracture. So I left it alone at that point of time, and I concentrated and focused on the articular surface. So that was my prime goal. Okay, so testiculum tali, yes, primary fixation is very important, and that is the goal. But sometimes in 30% of cases, you cannot do that. So you can leave those away, and you can get away with this without that by putting further fixation to the fracture fragments and the articular, maintain the Gisans angle. So that's my point of view.
Thank you so much, sir. So, Anjan sir, you can please.
Yes, because there is not so much of time.
Yeah, so, please, sir, you can start your presentation.
I'm giving just short 2 or 3 cases. So this is a minimal invasive in my way, what I am doing. This is a case 1. It is a 10 years follow-up for calcaneal fracture treated percutaneously. Patient profile is 18 years male. He came to me first consultation on 3 days after injury following jumping from a wall, and date of injury is 1st December 2010. Clinically, there is moderate swelling and ecchymosis on both heels. Initially treated with foot elevation and NSAID. Operation was done after 7th day of the injury. These are the pictures of the left heel, and this is the right heel. These are the pre-op picture, and post-op, these are the picture where reduced it and then put the posterior to anterior cannulated screws, but fully threaded so that there has been no compression. And we can maintain the length, height, and the width. So this is 18 months post-op, 8 months post-op, sorry.
So can you enlighten us with the reduction technique which you have used? How did you get that reduction done?
It's a bigger, it's a big time it's take.
Yeah, did you put a chest fixator initially?
In short, I shall tell you after the 3rd case. This is the left foot post-op. This is dorsiflexion and plantar flexion. This is the right foot post-op. This is the walking.
Anjan sir, do you want 2 minutes discussion on this case?
Yes.
Yeah, can you show the sir pre-op X-rays in this case? Smapat sir, what do you suggest? What you would have done in this case?
Okay, so very good case. I mean, we should do adequate to the calcaneal fracture. I always tell 3 things. Consider injury, consider patient, and consider surgeon. Now, since sir has done it 10 years back, he has absolutely done it up to the mark. So just do adequate. Now see here, the heel is in varus. Okay, fairly good articular alignment, as seen in axial. So our aim was to first bring him out of varus, gain the length. Okay, I would just put a K-wire medial to lateral or axial, pull it into good axial alignment, and then as he has done with few screws, or I will even pass some transarticular wire, whatever way you are comfortable, but reasonably good job done since he is young. Not only depend on interarticular alignment, but also depend on the other biomechanics. So very good approach to treat this. Very good.
So there is a intra-articular fracture communicating. There is a constant part, the sustentaculum part there.
Yes, yes.
You would like to put a screw in the sustentaculum part after getting the heel length?
Yes. Now you will not be see my arrow. What I was trying to show is posterior facet. You have to see at the posterior facet. Yeah, posterior facet and sustentaculum. This horizontal posterior facet and sustentaculum. If this is fairly aligned, no, horizontal at the sustentaculum talus. If it is here, if it is maintaining good, then you can avoid this screw. If it is not maintaining good, then that screw is essential.
So, but the part is rotated here and depressed. This fracture is depressed here in the lateral view, which we see.
Yeah. You just show me
so
that.
When if we elevate it, the rotation changes here.
Yeah,
also
then,
in the axial section.
Yeah, then you have to see if you need the sustentaculum screw, because that is the most vital screw for as far as the interarticular anatomy is concerned. So I agree with you. If I have to put the screw, that will be the important screw, sustentacular screw. So I will tell you the direction. It is lateral to medial, little posterior to anterior, and little caudal to cephalad. Most important, because sustentaculum talus is very dense bone. So you take a hold in that.
Actually, what we are doing, that is, we put one K-wire in the talus head and another in the posterior tuberosity.
Yeah.
So after that, we are keeping the distraction in both the sides. Then it comes, these sustentaculum fragments is coming almost in the same line.
Yes.
So sometimes we are putting this sustentaculum screw first. Otherwise, I put the posterior tuberosity and sustentaculum first. And later on, if that is necessary, then we put this from lateral to medial to hold the sustentaculum talus.
Absolutely.
These
a lot
always...
of time. Hello. Yes, a lot of time it happens even after distraction. This depressed part is an independent bone becomes.
Yes, so that time we are elevating these with this periosteum elevator from the both the sides.
Okay.
I show you after the third case.
Okay, sir. We can go on to the next case, sir, if everyone wants.
This is also 11 years, 10 months follow-up. So
we can't see your screen.
Oh, sorry. This is a 68 years aged diabetic male. Occupation is senior cardiologist in our place. So consultation is second day following the accidental fall from about a 10 feet height. Date of injury is 16th August 2008. Moderate tenderness and swelling around the right heel associated with ecchymosis. 5th day we are doing the operation due to correction of diabetes. So these are these injured side and the normal side. Pre-op X-rays. This is the axial view. This is the CT scan pre-op. So planned is closed reduction and percutaneous screw fixation. So done on 5th day of the injury in controlled diabetes after controlling the diet. This is the post-op picture. This is the pre-op and post-op lateral view. And this is this axial pre-op and post-op. So CT scan post-op. So 5 years follow-up. This is the Boden's view after 5 years. So uneventful post-op and no complaint till now. He is working many places. This is the working.
So can you show the pre-op and post-op X-rays together?
Yeah.
Sharad sir, are you there? Sharad sir, you're there? Nitin sir, can you hear us?
Yes, everybody is left, I think.
Yeah, Nitin sir, what do you think? Do you think that there is still this fracture is depressed a bit? Could have been elevated a bit?
It is still a depressed one. Buller's angle is not very well established, but clinically you are getting a good no issue.
Pal sir, do you think could have been done better? Because we have seen arthritis develops long after even the surgery. It takes around 8 to 10 years after.
It is
So-
11 years post-op. There is no pain till now because all the subtalar arthritis is happened in these due to these cartilage damage.
Yes.
But this clinical finding is not so much. Clinical finding is if there is lot of disturbance or malunion is there, then this problem is much more. Otherwise, if you maintain the length, height, and the axial rotation correct, little bit of difference is not a matter. That's the
Yes,
idea
very good.
of our things.
The outcome was very good, sir. But we don't have so much experience like 10 years follow-up like you have, sir. But just sharing, like I could see that the fracture was still depressed a bit.
Yeah, I agree with Dr. Anjan, sir, because just do adequate in these diabetics. If you try to do too much, then you may land up in soft tissue issue. And our patients, as he has rightly mentioned, they can tolerate even arthritis for a long time. But if you maintain the biomechanics right, they will do pretty well. So that's why I said just do adequate, considering injury, patient, and surgeon.
Yeah, Ujjwal sir wants to put some views in it too.
I just wanted to ask you, did you open the joint at all, or just from external maneuvers you have manipulated the fractures?
From the external maneuver.
External maneuvers.
But I am using this periosteum elevator from cutting both the sides with small nicks to lift up this subtalar joint.
So you have the X-ray the subtalar joint. Okay.
Excellent, sir. Follow-up you have, sir. I hope we can go to the next case. Before that, Smapat sir, can you enlighten us? The patient was diabetic.
Yes.
Will you go for a sinus tarsi approach or just a minimum invasive screw approach if the depressed fracture like this is not coming up much?
So I don't hesitate to go for sinus tarsi approach because healing is pretty good. Only thing is don't go for bulky implants. I agree. For elevation, I will go for a sinus tarsi approach.
Anjan sir, you can please continue.
Yeah. This is a 52-year male, hypertensive and smoker. Occupation is driver, is consultation after 3 days of the injury, is the car accident. Date of injury is 29/3/2009. Clinically right foot edematous with ecchymosis at right heel. Operation is done after 5 days of injury. This is the pre-op picture. The plan is percutaneous fixation of calcaneal fracture following ligamentotaxis. So this is the post-op picture. This is 6 weeks, after 6 weeks. This is after 4 months.
Yes, sir. Can you? You're telling the surgical step. Okay, please go on, sir.
I just mentioning these steps. That is usually we are doing in prone position, below under this leg. First, check this image intensifier in axial and this lateral and little bit with rotation Borden's view. No tourniquet is applied. Check the image intensifier like this. And then put 2 K-wires parallel to this fracture line. So first K-wire is in the talus and another is in the tuberosity. And then apply distractor on both sides. Medial should be more because of this varus. And sometimes we have to, when it is impacted, then we have to disimpact with this periosteum elevator, this medial side. And then again put the traction, and then I am using some vice, innovative type. It is a vice. So we are using this. It has a concave and convex sides. So I can use that according to this fracture. And then these percutaneous guide wires from posterior to anterior. And then remove the vice and see in this lateral position so that it's in the subtalar region. And it acts as a and cannulated screw fixation from through these guide wires, that is 1.6 millimeter guide wire. So these 3.5 millimeter screws are putting, and the additional screws is in the sustainabulum tali from lateral to medial.
Sir, can you take us to the pre-op and post-op X-ray, sir, of this patient? So excellent demonstration of the procedure which you did. Yeah, sir. Next slide, sir. Next slide. Where this is the pre-op, sir. Pre-op, yeah. This one, yeah. Post-op, sir. You can keep it here. Smapat, sir, or Nitin, sir. What do you suggest about what you would have done in this case?
It is an excellent reduction. Apart from the subtalar joint arthritis, most common issue what we see in the calcaneum is the lateral wall blowout and peroneal tendinitis. Yeah. So here the lateral wall is excellently reconstructed apart from the subtalar joint. So patient has an excellent result while walking. These are my observations.
Sir, next X-ray, post-op X-ray, can you take us to the next post-op X-ray?
Yeah.
Yeah, this screw.
Yeah.
Do you think there is a problem with the third screw? Smapat, sir, you were telling something.
Due to this X-ray variation, because you can see these one. Sorry. Not.
You can go to previous slides there from clicking on your.
Another slide is there.
Move one more.
One slide back.
One more slide back, sir.
I don't think that does matter because there are 2 screws already in good position. And the third one as well is going through the bone. It may be showing in this view that something is out, yes, but it is
due to this view of this.
Yeah. So I would accept, it's nice, very well done. But the problem here, you see, my that sustentaculum tali, it did not be fixed here. So that was one. This is the example of this kind of fracture. Sometimes you don't need a screw.
This is the fragment of the sustentaculum tali.
Yeah. This one.
Yeah. Well, it was fixed.
Just a comment. Yes.
Yes, Paul, sir. You want to?
Actually, I am following this technique as Dr. Pan is suggested. I am very much satisfied with this technique, which I followed actually. See this radiograph. This is a very, very good radiograph. You can see here the talus is going inside that there is a impaction of the talar head inside the calcaneal shadow, isn't it? So the distraction, which is, so the first step where I do the distraction, that may be the talocalcaneal distraction. So that talocalcaneal distraction that disimpacts that the impaction of the talus in between the calcaneum. That is first. Second one, see the width is increased. The width should be taken care of with the help of the vice, as Dr. Pan suggested. But actually, I improvised with the 5 rupee coin, which is indented, indentation by preferably made, and it is autoclave, and that can be placed on both sides. That can be placed depending on the fracture, and with the help of the C arm. So that can be placed anywhere by this lateral or medial wall of the calcaneum, just before correcting the varus correction of the calcaneum and the correction of the length. Then the width is corrected by pressing that coin both the side with the help of the patella holding clamp, or the any clamp which can graduated that can be that is compressed from side to side. You understand? So
Yes,
once I am
yes.
very much satisfied with the correction of the width, so now the length is corrected. Now the width is also corrected. Now we have to see, we have to concentrate on the subtalar joint. Now the subtalar joint, if it is, that may be automatically that can be corrected. If it is very lateral, see the first fracture line comes on the lateral side. Next in the side, either central on the medial side. See here, there is a lateral, there is a one lateral side fracture line, another is the medial, but medial side is not very much displaced, lateral is little bit displaced. Both the
Yes,
central component and the medial components both are depressed. Okay,
Yes, yes.
so once we distract, automatically that may correct by spontaneously, or in that case, if it is not corrected, then in that case we can do a lateral window, either by the percutaneous technique, or the lateral window, as Dr. Anjan suggested, with the help of a small anything which can push, like to elevation of the lateral tibial plateau, we can introduce from the lateral wall through the fracture side, either.
Anjan sir, can you make the screen full? Actually, no one can see.
Yes, either we have to use the sinus tarsi approach, or the middle part, as basically the middle part of the sinus tarsi approach, so that we can just open it, and we can, for the middle part easily we can go through the go up to the fracture site, and that can be elevated. And then if you once I'm very much satisfied with the elevation, and in that case it is very important to see the Broaden's view. See, this is most important, Broaden's view, because actual view is not very for reduction. So Broaden's view, if it is satisfactory, then only we have give this girder screw, as you can see here, these 3 girder screw. So is girders actually for the girder screw should be plus. It's not the girder screw, actually the 3 guide wires first. Next the lateral to medial screw first, then these 3 screw. Lateral to medial screw should be half threaded, so that will compress the lateral wall to the sustentaculum tali. Preferably we have to try to hold the sustentaculum tali, but there is a very little amount of bone, that is bone window. So it will be very much careful, so that the joint side will not be violated. This is that is the tricky component from the lateral to medial screw. And last, then we'll pass the 3 fully threaded screw from anterior to posterior to anterior side. You understand? This is my technique. I am very much satisfied enough with this technique. I have also 5 years of follow-up study, and basically I have gone through the article. They have shown that up to Saunders type 2, it is very highly, it is superior to open reduction, but it is type 3 and type 4 results are equivalent, and on both the open method, and also the minimally invasive technique. Another, the evidence-based medicine, which suggested that whatever treatment you offer for the Saunders type and type 3 and type 4, there is 100% incidence of post-traumatic osteoarthritis, subtalar osteoarthritis over the period of time.
That's true.
So if it is the scenario, so why you don't to use the MIS? Because in minimalistic surgery, at least we can prevent the soft tissue complications at least.
And even restore the hind foot mechanism, even the alignment of hind foot.
Through the article, there are all the evidence-based studies, study shows that over 15 to 20 years time, the 100% patients of all Saunders type 3 and type 4 shows the post-traumatic osteoarthritis, whatever the method of treatment. Whatever.
That's true.
Saunders 4 requires a primary arthrodesis, whatever happens, because that helps to get away with whatever one surgery will help the patient to get on through the life. So that is my viewpoint. The Saunders 4 I'll treat with no fixation, but to do a fusion.
Maybe.
I also agree.
Another advantage of these, that whenever you go for the subtalar orthodesis, then also you don't have this problem with this scarring of the skin.
Yes.
Because there is no other scar before that.
That's right. That is also yes.
Dr. Shiv Acharya has asked, he did not understand the procedure. Actually, sir has told distraction and then the percutaneous screw fixation.
Can I repeat this? Can I repeat this? Yes. Can I repeat this? Repeat
Yes,
the
sir,
procedure.
please, in short, sir. It's just too. Yes, sir.
Just
make
in
it simple.
short.
Yeah.
Yes, simple. Yeah. First stage, we have to restore the length of the calcaneum. Length of the calcaneum can be restored with the help of the one K-wire, 2.5 to 3 millimeter K-wire through the head or neck of the talus, another through the tuberosity, which is intact part of the tuberosity of the calcaneum, through and through, lateral to medial. On both sides, we have to apply the distractor, that is just distractor. We have to distract depending on the situation to correct its alignment. If maybe it is a varus, so we have to correct much more distraction on the medial side like that. So first, once the alignment is corrected, then the next step, side to side compression to correct the width. So in that case, either the vice or the any sort of compression from side to side to correct the width, and that has to be confirmed with the help of the axial view. Once the axial view we are satisfied, then we have to convert into the Broaden's view. We have to see whether the subtalar component is depressed or not. If it is maybe automatically corrected, then it is okay. Then we have to push the girder screws and either the girder screw or one or two oblique screws. Otherwise, we have to correct it with the help of the percutaneous reduction technique or through the sinus approach. And then first from the lateral to medial screw, followed by the posterior to anterior screw. And then if required, there is either the upward down screw or down to up screw. That is a vertical screw, one or two. So this is the method. First, correction of the distraction. Next is width correction. Next is subtalar articular depression correction.
Thank you so much, sir. Thank you. I would like to thank all the panelists, Professor A.K. Pal, Dr. Mandeep Dhillion, Sharad sir, Smapat sir, Nitin sir, Anjan sir, and Dr. Bakshi for being a part of this webinar. We had more than 1,000 views for this webinars. I thank you everyone for being a part of it. And it was very enlightening for everyone. Just a 2 or 3 minute session by Dr. Veena will like to share a slide share.
Yeah, please.